Okay, guys. Today we have a very nice and very interesting topic. I think all of us liked it. It's more practical, more of a daily life, daily practice. You see a lot of these cases. We'll talk about the imaging findings in metabolic bone disease. Your fellow colleague, Dr. Abbas, will tell us about it.
Thank you very much, Dr. Ahmed, and thank you for my colleagues. Today, we will discuss the imaging finding of metabolic bone disease. These are the main topics today. We want to discuss them. I wrote all of them: osteoporosis, rickets, osteomalacia, hypophosphatasia, hyperparathyroidism, and so on. We will try to discuss one by one. At first, osteoporosis. Osteoporosis is a condition characterized by diminished but otherwise normal bone. So there is decrease in the quantity, but the quality of bone is the same. But there is a decrease in the bone mass or the quantity of the bone. This is the most common metabolic bone disease, affecting 13 to 18% of women older than 50 years, while it affecting 1 to 4% of men older than 50 years. So it is more common in females. It results in substantial morbidity and mortality. That's why osteoporosis is an important subject, because it results in substantial morbidity and mortality, primarily through the fracture worldwide, primarily through the fracture. In the worldwide, one osteoporotic fracture occurs almost every 3 seconds in the world, which results in 9 million fractures each year. This is significant deformity or morbidity. As we say, the main problem is through the fracture. Here we have some examples of osteoporotic fractures. I think the most common one occur in the vertebral body and in the femur, such as you see here, subcapital fracture. We see this Colles fracture and humeral fracture. As we see, the bones are there is decreasing bone density. There is decreased bone density. That's why they said osteoporotic fracture which occur after mild trauma. If you say there is osteoporosis by X-ray, it is just depend on the radiologist or the one who reads the X-ray. But when you definitely say it's osteoporosis, you need bone densimetry. So the bone density that is 2.5 or more standard deviation less than that of a young, healthy adult mineral. This is called osteoporosis. We have 2 types of osteoporosis, the primary and secondary one. The primary takes slightly different forms in men and women, as we said. It is commoner in female and mostly due to postmenopausal. And you have in the primary another type, you have senile. Senile occur in both male and females. Standard deviation. Yes. Two more. Yani 2 point. It is most accurate if you compare you in the senile one with same patient in the head. So in types you have primary and secondary. And primary we have two types. We said postmenopausal and senile one. While in the secondary are due to other causes such as Cushing syndrome. I'm not going to detail this. This is an example of osteoporosis, how to different from this one in 17 years old, 57 and 82 years old. Here we don't see trabeculae, but you see normal bone. But here, if you're comparing this one, there is appearing of the trabeculae with loss of most of the horizontal fibers. These are the horizontal. That's why the vertical fibers appear coarse. It is appear not like that. But when we compare with 82 years old, there is a coarsening, or the trabeculae are, could be seen better. So we finished osteoporosis. Now we're going to rickets. Rickets is the interruption of the orderly development and mineralization of growth plate, result in interruption of orderly development and mineralization of growth plate. Rachitic manifestations are most prominent at the sites of the greatest growth, such as distal humerus, distal femur, distal radius, and ulnar. This is a pathology of how rickets needs to be evaluated, so that the vitamin D precursors in the skin, in the liver, 125 dihydroxycholecalciferol, then change it. I'm not going to this detail because we want to concentrate on the radiological finding. This is the findings of rickets. We have the extremity in the chest and the skull. In the extremity, there is a widened growth plate at first if there is active rickets, and we have healing phase of the rickets. At the active phase, there is widening of the growth plate, irregular and osteopenia along the metaphyseal side of the growth plate, flared, frayed, or fractured metaphysis, and finally bowing on the fractures. While in the healing phase, the extremity, in the healing phase, there is widened growth plate, especially in the distal femur, mild metaphyseal cupping. Instead of osteopenia, there is sclerosis along the metaphyseal side of the growth plate, and also there is bowing. In the chest, we have two manifestations, rachitic rosary and bell-shaped thorax. Later, we will try to see them. And in the skull, there is flat occiput, widened suture, squared appearance of the skull, and basilar invagination. This is an example of 3-year-old child with rickets neglected by the parents. Here, in the 3-year, there is a widening of the suture, sagittal suture, and in the chest view, rachitic rosary, although it's a little bit not quite obvious, but what's rachitic rosary is the widening of the anterior ends of the ribs, anterior ends of one rib, just like rachitic in the rosary. Muru basere in this one, there is cupping and fraying of the metaphyseal metaphysis. It's easily seen here. There is a fracture because, as we said, there's neglected. It is neglected, and also incidental fractures are seen because bone is liable to fracture. And this is after, yes, osteopenia or osteopenia. This is after treatment. We say after treatment there is a sclerosis at the metaphyseal side of the growth plate, because this is growth plate, this is lucency, and this is the metaphysis. Here, there is development of a zone of provisional calcification and a dense line seen at the metaphyseal side. We shift to osteomalacia. Osteomalacia is inadequate or abnormal mineralization of osteoid in the cortex and trabecular bone. There is decreased bone mass is frequently observed in the osteomalacia. However, it is not an essential feature in the diagnosis. Well, it's an essential feature in the osteoporosis. We have two terms in the radiological finding of osteomalacia. First, poor quality radiograph. This is the result from the presence of large quantities of unmineralized osteoid can sometimes be observed as indistinct, ill-defined trabeculae. Well, the most important or the hallmark of osteomalacia is loser zone. Loser zones also known as pseudofracture. It's a type of insufficiency fracture occur late in the course of the disease, results of a deposition of unmineralized osteoid at the sites of stress or along nutrient vessels. It can occur with no or with minimal trauma, often bilateral and symmetrical, appear as transverse lucent band oriented at right angles to the cortex that only span a portion of the bone diameter, not all of them. It is typically painful. Some of the common locations of the loser zone are similar to those of stress fractures. However, loser zones are also occur in non-weight bearing, which are atypical for location of stress fractures, such as in the scapular or the outer edge of the femur or the lateral aspect of the femur. These are uncommon sites for stress fracture, but it is common for loser zones. Here we see in the vertebra, this one a little bit also not obvious, but these point us to multiple fractures in the vertebral fracture. Yes. 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 And this is also pointers to some of the loser zones here. That's why I skipped this here. Hypophosphatasia, another topic, hypophosphatasia. It's a rare genetic disorder caused by mutation in the gene that encode tissue non-specific alkaline phosphatase, resulting in accumulation of pyrophosphate, which is an inhibitor of bone mineralization. So there is defect in the bone mineralization in hypophosphatasia. The skeletal findings of hypophosphatasia resemble those of rickets and osteomalacia. Because rickets and osteomalacia also there is hypophosphatasia. It's categorized into the following phenotypes in the decreasing of severity: perinatal, infantile, childhood, and adult. This is an example of infantile hypophosphatasia, in which in this X-ray we see only patchy bone mineralization in the skull vault, in the facial, and we see only little amount of bone in the facial bones, in the cranium, in the axial. Here, there is no axial, no vertebra, but they could be seen. Small clavicle, small humerus. Yes. 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 Of course, antenatal ultrasound is also there's like discrepancy and. This is again a case of hypophosphatasia. This is called copper-beaten appearance of the skull. Also, there's widening of the anterior enders of the ribs, just like rickets, and of course, osteopenia and widening curve plates could be seen. This is also another example of hypophosphatasia, in which small clavicle could be seen, and all of bones, especially in the facial bones, are underdeveloped. Yes. Shift to the most important one is hyperparathyroidism. Hyperparathyroidism, this is the action of physiology of the parathyroid hormone. There is phosphate diuresis, resorption of the calcium and phosphate from the bone, so it results in bone resorption. While in the serum, there is it acts to increase in the calcium and decrease phosphate. Secondary function, the resorption of the calcium from the gut, resorption from calcium from the renal tubules. So bring calcium from everywhere to the serum, just elevating serum calcium. Again, we have primary and secondary hyperparathyroidism. Primary one, usually adenoma, about 90% is due to parathyroid adenoma, 10% due to hyperplasia, and rarely due to carcinoma of the parathyroid. And the secondary is more common than primary. It is the response of low serum calcium level, which stimulate parathyroid hormone to secrete parathyroid hormone. The most common cause is renal failure. Chronic renal failure is the most common cause of secondary hyperparathyroidism. Radiological finding, subperiosteal bone resorption, which can be seen in the hands in about 95% of cases of hyperparathyroidism, and it's regarded as a pathognomic for hyperparathyroidism, usually occur in the radial aspect of the middle phalanges of the middle and index finger. Radial aspect of the middle and index finger, and there is bone resorption as a lace-like irregularity. As we see here, there is bone resorption or subperiosteal bone resorption at the radial aspect of the middle phalanges of the index and middle finger. Another one is acroosteolysis. Acroosteolysis occurs in the distal phalangeal tuft at the later stage of the hyperparathyroidism, not in early phase. The resorption can appear similar to scalloping or periosteal reaction. It's called pseudoperiostitis. This is to show acroosteolysis due to hyperparathyroidism. It's occurring in the distal interphalangeal joints. Subperiosteal bone resorption can also be observed in the ribs, in the lamina dura of the teeth, in the humerus, femur, and upper medial tibia. This is subperiosteal bone resorption and acroosteolysis. Another feature of hyperparathyroidism is trabecular resorption. Trabecular resorption results in a smudgy or hazy appearance of the trabeculae. Intracortical resorption is also described as a cortical tunneling and is often prominent feature. Cortical tunneling due subperiosteal bone resorption also. Another finding in hyperparathyroidism is subchondral resorption. Subchondral resorption affects any joint, leading to a widening of the joint space and irregular appearance. In the hands, subchondral resorption most often begins along the distal interphalangeal joint and progress to the metacarpophalangeal and proximal interphalangeal joint. In the hand, subchondral resorption, as we said, most often begin along the distal interphalangeal joints and progress to the metacarpophalangeal and proximal interphalangeal joints. Subchondral resorption can also occur along the acromioclavicular joint. The acromioclavicular joint is most pronounced along the clavicular side, while in the sacroiliac joint, subchondral bone resorption is more pronounced at the iliac side, here, and may simulate inflammatory or infectious arthritis. So there is widening of the joint space and more distal.
Then moves to the metaclavicular, then towards the proximal metatarsal. It's fixed, then goes back. Okay? And this moves to proximal, and then proximal. Okay? It's just a small trick. In the metaclavicular, it starts with the clavicle. It's a whole list of causes of clavicular resorption. Okay?
Yes.
It's very long problem. When you take the left side joint and iliac side, then the bilateral, more than the iliac.
Yes.
Okay?
Another finding in hyperparathyroidism is subligamentous or subtendinous bone resorption. It also occur anywhere, but most often occur along the calcaneus, clavicle, greater and lesser tuberosities of the humerus, greater and lesser trochanterus of the femur, anterior and inferior iliac spine, and ischial tuberosities. I think we have another mention. In the skull, there is appearance called salt and pepper appearance, or due to mottled appearance of the skull vault due to lucency and the remaining bone. Can lead to decreased differentiation between the inner and outer table of the skull. So this is what's called salt and pepper appearance. Due to mottled, and it's described as a mottled appearance due to bone resorption. Another finding is, and the most important I think for MCQ also, brown tumor. It's called osteoclastoma. It's a late elliptic lesion that results from the parathyroid hormone-driven activation of osteoclastes. Generally, they are solitary, but it can be multifocal. They are at risk of pathological fracture and commonly involve the facial bones, ribs, pelvis, and femora, and can have a large associated soft tissue component. At this time, it's cellulite tumor. More common in the patient with chronic renal insufficiency and secondary hyperparathyroidism.
This brown tumor, tumor,
I think it's
it's not a tumor. It's not
tumor
process.
mind.
It's due to the activation of osteoclast resorts the bone extracardiac. Okay? يعني حصل تحول. Okay, this clarity, the body will react with virus. Blood and humor, it looks brown, that's why they call it brown. And it looks uncertain like a mass, they call it brown tumor. But it's not a tumor, it's just normal tissue. يعني if you put a ball in the bone, the body will tell you the same thing. يعني that's why also, before also before there will be myeloma operation and things like that, and also brown tissue. But it's sector also but it's not a tumor, just a tumor. It's a cover. Okay? It's just acting the one followed by virus tissue. Not neoplastic process.
And also previously they said brown tumor is more common in primary, especially in all Texas. But yes. This is a picture with we said subperiosteal bone resorption and acro osteolysis in the distal phalanx, distal cuff. There is a fracture. This is a salt and pepper appearance of, as we said, and this is, as we said, smudgy, trabecular, and tunneling. I didn't see tunnel exactly. This is a subchondral bone resorption, as we said, and this one is subtendinous resorption there at the side of hamstring and the adductor. This is also resorption in the acromioclavicular. This is a brown tumor, also a brown tumor here in the distal femur. This is look like the case where we showed in the sun. Brown tumor with soft tissue component, and they did maybe scan for hyperparathyroidism. There is a focus of a hotspot in the parathyroid region. Shift to another topic, renal osteodystrophy. By the way, renal osteodystrophy is also a cause of secondary hyperparathyroidism. Renal osteodystrophy, we won't concentrate just on the findings. There is diffuse increase in the bone radiodensity, more often in the skeleton. Also, there is increase in the bone density, but the bones are weak and prone to stress fractures. Such as this radiograph, we see there is a diffuse increase in the bone density, especially in the axial skeleton. Another term is Ruger-Jersey spine. It's called, I think, this is because it looks like the T-shirt of a team. Yes. Yes. And this is due to alternating bands of high density with radial density. due to alternative bands of radio density in the lattice and lucency along the mid portion of the. Another one is the soft tissue deposition of the calcium. As we see in this radiograph, there's faint calcification present in the posterior aspect of the forearm. There is chondrocalcinosis, in the chondrocytes, in the pinna, and also in the abdominal wall. So soft tissue deposits of calcium is another feature of secondary hypoparathyroidism and renal osteodystrophy. Another one is amyloid deposition, which can lead to carpal tunnel syndrome and destructive arthropathy. As we see here, there is a lytic lesion causing destructive arthropathy at the head of the femur and partially involving the neck. Also due to amyloid deposition in the end-stage of renal osteodystrophy. Shift to hypoparathyroidism. We're not going to detail of pseudo and just radiological findings of hypoparathyroidism. There is increase in the bone mass, including generalized or localized osteosclerosis. That is the reverse of hypoparathyroidism. There is thickening of the calvaria with narrow diplo space. In rare cases, there is spinal ossification. You have no picture for hypoparathyroidism. We need to shift to hypothyroidism. And in hypothyroidism, we have congenital, which leads to severe skeletal abnormality and delayed development. And we have acquired, which results in a relatively mild skeletal abnormality, if any.
What does it call?
Children, there is a delayed skeletal development, often with absent, irregular, fragmented distal femoral and proximal tibia, tibial epiphysis, resembling multiple epiphyseal dysplasia. And also there is dental development may also be delayed in hypothyroidism. This is a case of hypothyroidism. The findings are short stature and developmental delay, hypoplastic bullet-shaped vertebral body. These are hypoplastic and bullet-shaped vertebral bodies. Flaring iliac bones and shallow acetabuli. There is shallow acetabuli that are susceptible to slipped capital femoral epiphysis and TDS. Femoral capital epiphysis and tibia are small and fragmented. These are small. For that, this is also a case of hypothyroidism. There is development of the epiphysis, but it is small and irregular. While after treatment, there is it became large, but there is some flaring also could be seen. This one, another example of hypothyroidism. In the 12-year-old, there is only ossification or appearing of capitate and hamate, while after treatment at the 12th year, and this one in 14 years after 2 years of treatment, there is development of all and appearing of all carpal bones. Another one is hyperthyroidism. Hyperthyroidism, again, radiological finding, there is osteoporosis. Osteoporosis is the most common skeletal manifestation of hyperthyroidism. We have thyroid acropathy to occur in 1% of patients, usually occur after treatment when the patient's condition becomes euthyroid or hypothyroid. Best observed in the hands and feet, in which clubbing, peritonitis, and soft tissue swelling may be seen. The peritonitis is greatest along, again, just like hyperparathyroidism, greatest along the radial margin of the metacarpal, metatarsal, and middle and proximal interphalangeal nerves. So another finding, despite the osteoporosis and thyroid acropathy, there is soft tissue swelling, which may be also be seen in the pretibial region called pretibial myxedema. Exophthalmos, which results in the thyroid stimulating hormone receptor stimulating antibodies of the Graves' disease stimulating a proliferation of retroorbital fibrosis, which may be depicted in the skull radiograph or head CT. Again, we have no picture for hyperthyroidism. Shift to acromegaly. Acromegaly, these are radiological findings in the hand. There is spade-shaped tufts, spade hakanas. There is tubulation of the phalangeal shaft, exostosis, widened joint space, and sesamoid enlargement. Another common site for acromegaly to be seen is heel pad thickness. I think it's better to see image. This is a spade-shaped phalangeal tuft, as we see. In the hand, in the feet, there is increase in the heel fat pad thickness, more than 25 millimeter in men and more than 23 millimeter in the women. This is a heel pad thickness. Also, there is skin thickness, increasing the skin, and tendon insertion, ossification, and sesamoid enlargement also could be seen. In the skull, thick skull bones, enlarged cella, it's either due to pituitary tumor or due to either feature of acromegaly. Enlarged cella, frontal boozing, prominent of the frontal and maxillary sinuses, supraorbital reeds, and zygomatic arch, prognathism, that's to say protrusion of the jaw, and enlargement of the mandible. It does look like a shrimp. And the last topic is scurvy. Scurvy is a vitamin C deficiency, results in the abnormal collagen production, leading to the vascular fragility and abnormal bone matrix. The bones are diffusely osteopenic, and there are thin cortices, especially in the epiphysis along the growth plate. Irregular appearance of the growth plate along the metaphyseal side. A dense band along the metaphyseal side of the growth plate, called Franklin line, in the zone of provisional calcification, represents a sclerotic provisional zone of calcification. I think it's better to shift to the imaging. Here we can summarize the findings in scurvy: osteopenia and thin cortex. If it's not obvious, it is quietly obvious. Here there is osteopenia, irregular growth plates. It's a growth plate, this one, and this one is irregular. Franklin line is this one, this sclerotic band. Yes. Trauma-felt zone. This point. Below. That's under the Franklin line. Franklin, it's the sclerosis and Picking is a this is called picking when the trauma field, the Franklin line extend beyond its epiphysis and metaphyseal region. It's called picking. And another one is peristyle reaction. This points to the peristyle reaction, although it's somewhat heterogeneous. Another feature of scurvy is subepiphyseal corner fracture. There is, if you see, there is a small radiolucent line representing a subepiphyseal corner fracture, which could be a differential diagnosis for non-incidental injury. So in MR, there is a heterogeneous on T1 and T2, and also there is subperiosteal hemorrhage, which appears as a hyperintense region in the T2 weighted fast saturated sequence. Also, areas of heterogeneity or the high signal intensity could be seen in this region due to hemorrhage as a result of vitamin deficiency. Yes. Thank you for your question.